You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for April 14th, 2023. This week, some brief listener feedback, SCAI, a consensus document on left atrial appendage closure, Semaglutide and Tirzepatide disruption, nonsteroidal anti-inflammatory drugs, and interventional echocardiography. First, I want to just do some listener feedback. A listener pushed back on my covers last week of large language models. Listener wrote, quote, "While I agree that large language models have a lot of potential, please don't hype papers which basically have large language models regurgitate text, which is quite similar to stuff on the internet. Also, please talk about how the references that the ChatGPT provides are often fake and they must be verified anyway." Finally, the listener wrote, "What happens when the AI scribe misses a point? How should society view this compared to a human scribe error? What are the implications for burnout of having to check for AI errors, which may be in some ways more smoothly hidden than human transcription errors?" Now, I did some testing this week, and the ChatGPT cranked out completely broken references and links. And what's weird is that when I pointed this out to the ChatGPT in a follow-up question, the computer simply said, "Sorry, here are the correct links," and they were the same broken links. Okay, like I said, this is the first inning of using AI, so stay tuned. We're going to be talking about this a lot more. The second topic is that the Journal of the Society of Cardiac Angiography and Interventions, SCAI, SCAI, has published an expert consensus document on left atrial appendage closure. SCAI and HRS commissioned the document, and the ACC and the Society of Cardiovascular Computed Tomography have endorsed the document. Professor Jacqueline Saw is first author. SCAI also published an important editorial from two very clear thinkers in cardiology, Drs. Faisal Merchant and Mohammed Al-Kuli. Now, first some summary points, then some comments, including a comparison to the ESC consensus document on left atrial appendage closure, which was published in 2020 with Professor Glickson as first author. The SCAI document makes their first and, I think, strongest focus on patient selection. They write, "Those with high stroke risk, not suited for long-term oral anticoagulation," and quote, "who have an adequate life expectancy, minimum greater than 1 year, and quality of life to benefit from left atrial appendage closure." I think that phrase is an important phrase, and I'll come back to it. SCAI also makes recommendations regarding experience, but as the editorialists write, these are empirical. Translation, they are just simple guesses about how much experience an operator should have. SCAI makes general recommendations on imaging, but ultimately this will be left to the discretion of the operators. There are also recommendations on post-procedure imaging at 45 to 90 days after closure. And finally, interestingly, they recommend against combination procedures wherein left atrial appendage closure is done along with PVI or other structural procedures, and they cite the lack of data for this. So my comments, I laud the emphasis on patient selection. Good on the authors. As many of you know, my review of the seminal trials of this procedure lead me to believe that having a device is clearly worse than warfarin, unlikely to be better than DOACs, and perhaps worse than no treatment in truly anticoagulation ineligible patients. But I am an outlier, and I accept that. Like I have said, I've lost the left atrial appendage debate on 5 continents, though I have another chance this week in Portugal. For the rest of my comments, I will pretend the seminal trial data don't exist. But the authors are right to focus on patient selection because what I have seen in the literature and witnessed at our neighboring hospitals here leads me to believe we are choosing patients least likely to benefit. In my very first debate, a crushing loss to Professor Horst Sievert in front of a huge crowd at ESC, even he, one of the world's most vocal and eminent proponents of percutaneous closure, said in the Q&A that older patients with multimorbidity are the least likely to benefit from this procedure. Why would that be? It's because of Andrew Foy's 4 domains of treatment effect. That is, the flip side of treatment benefit is treatment harm. Older, frailer patients are at higher risk for procedural harm. And the flip side of the risk of an outcome, such as stroke or bleeding, is the competing causes of other bad outcomes. Here, older, frailer patients may have higher stroke risk from emboli, but they also have higher stroke risk from vascular causes. Competing risk is one of the most important concepts of deploying therapy in complex patients. It is one of the core problems with treating patients with HFpEF, for instance. Poor patient selection is not my opinion. There are registry papers showing that U.S. implanters are choosing patients with much more comorbidity than those in the seminal trials. I've co-authored one of these, and I've cited it previously on this podcast. Sadly, and I hope it isn't our susceptibility to marketing, we are choosing to do this procedure. We, as in U.S. physicians, are choosing to do this preventive procedure in patients least likely to benefit. Hear what the editorialists write. Atrial fibrillation is increasingly prevalent in the elderly and those with multimorbidity. Many of the patients will reach an age or level of morbidity or frailty where long-term anticoagulation is no longer a safe option. Should all of these patients undergo left atrial appendage closure? Answer, quote, certainly not, end quote. Now, the authors add the statement about expectation of 1-year lifespan, which I think is better than nothing, but, in my opinion, it's unlikely to improve decision-making. And I say that because of history. The ICD recommendations had a similar statement, and it did not stop the egregious use of ICDs in frail elderly patients who had no chance of benefiting from a preventive device. This happened during the period of irrational exuberance of ICD use. Now, another comment on the excellent editorial. Merchant and Alcooley tell us that there have been more than 100,000 appendage closure procedures done at more than 650 implanting sites. Pause there, stop, and think. One of my greatest sources of regret about this field of cardiology is that if a fraction of these patients were randomized, we would already have the answers about this procedure. It's a darn tragedy. If said trials showed benefit, I'd be a leading implanter and proponent. But if said trials found no benefit or harm, imagine the downsides. 100,000 procedures with very little data. Gosh. On the matter of training and expertise, SCAI is correct to set out some degree of standards, though these standards should be very loose. I'll talk more about that in the last topic. I have learned that some hospitals in the U.S. have multiple low-volume implanters. Small hospitals with 4 or 5 implanters is exactly not how to do procedures like this. I have friends from super high-volume centers who tell me, John, the learning curve involves hundreds of cases. So if we wanted to do this procedure in the right way, it would be like lead extraction. You choose a small number of operators and you let them do the bulk of the cases. All right, another important section in this document is the matter of imaging to improve closure and assess for these peri-device leaks, which are so problematic. The editorialists rightly worry because the recommendation to do transesophageal echo typically occurs at 45 to 90 days, and that's when most patients are still on a relatively intense antithrombotic regimen. They write, quote, thrombus may not form on a device until the regimen is tapered. Therefore, the reported incidence of device-related thrombus of 3 to 5% may be an underestimate, end quote. Finally, I would like to contrast this document from SCAI with the ESC document. SCAI document includes no words on the debate surrounding the existing data. SCAI makes the assumption that this procedure works, period. ESC, however, asked John, Cam, and I to detail the controversies surrounding the data. I will link to that ESC document. It includes Chapter 6, the title of which is Left Atrial Appendage Occlusion versus Oral Anticoagulants, Doubts and Unresolved Issues Regarding Existing Data. Okay, so one of my assigned talks at the Portuguese Cardiac Society meeting, which I'm leaving for today, is medical necessity versus therapeutic fashion, or the reason why we voraciously believe every clinical trial. Now, the transformation of this procedure, left atrial appendage closure, to an ensconced therapeutic fashion, and surely it is a therapeutic fashion because there have been 100,000 procedures performed, is a great example of voraciously believing clinical trials. I mean, do you know how many patients were in PROTECT AF and PREVAIL? About 1,100. And Watchman did not meet non-inferiority in its first primary efficacy endpoint of stroke, systemic embolism, and CV death in PREVAIL. So, based on less than 1,000 patients who had this device in trials versus warfarin, U.S. doctors have done over 100,000 procedures. That is remarkable to me. Now, there are two big trials ongoing, left atrial appendage closure versus DOACs in any AF patient eligible for anticoagulation, Champion AF and Catalyst. These are expected to report in 2027 and 2029, and I hope I'm alive to see the results. Okay, the next topic is disruption in the diet industry from Semaglutide and Tirzepatide. 3 journalists from the Wall Street Journal reported on this disruption in the weight loss market from these 2 drugs. Now, since I talk to patients nearly every day about losing weight, and since these drugs clearly cause weight loss, I will briefly mention a few more things that I learned this week about this topic. The first thing is that the reporters modified diet industry with $76 billion. Now, I knew it was a lot, but $76 billion. These drugs are going to seriously disrupt the status quo, aren't they? And there's tension here. On the one hand, obesity is bad, and the drugs work. I mean, 10 to 15% body weight loss will lead to all sorts of better health parameters, lower blood pressure, better glucose control, to name just a few. And these are good things. No, actually, these are great things. But opposing that benefit is nearly the entire diet industry, which has essentially been focused on diets of one sort of another, right? The question, therefore, is what will the diet industry do? Because if they embrace these drugs, there's much less need to sell diet plans, meal plans, exercise programs, etc. For instance, Weight Watchers has spent the last 60 years telling its members they can lose weight by tracking the food they eat, doing frequent weight checks, and making other lifestyle changes. But subscribers to Weight Watchers is declining. People seem to be voting with their feet, which I understand because Weight Watchers is sort of hard. Now, the journalists tell us that Weight Watchers are buying a telehealth company that connects Weight Watchers members to doctors who often prescribe Semaglutide and Tirzepatide. So I think we're at the beginning of a new chapter, and I don't know what will happen. One barrier, of course, for rapid adoption of these drugs will be high cost. So if effective in the long term, it will be another therapy that increases these disparities in health access because, people with poor or no insurance will not be able to afford these drugs. Okay, another thing I learned this week, sounds small, I learned it from Twitter, is that Tirzepatide increases the rate of alopecia 5 times over placebo, 5x. Now, I could not find it reported in the Semaglutide trial. And you think that's nothing. Oh, come on, Mandrola, that's nothing. Well, you should think again, because I've had many a struggle convincing patients who are losing their hair to stay on an effective drug. So I guess you can input this side effect, alopecia, and it is clearly signal, not noise, into the there is no free lunch when it comes to medications category. All right, next topic is NSAIDs. Jack has published an observational study from Danish authors regarding the association of NSAIDs, heart failure, and type 2 diabetes. The authors used their Danish nationwide registry and found short-term use of NSAIDs was associated with an increased risk of heart failure hospitalizations. The odds ratio was 1.43 and significant. It was most notably in subgroups with age greater than 80 years or patients with elevated hemoglobin A1C levels who took anti-diabetic drugs. Now, I cover this story because it's sort of an outlier, isn't it? It's an outlier in that you've heard me say how fast medicine can change, how old trials ought to have expiration dates, how 3 of the procedures I do most often today were not even thought of when I did EP training. Well, not NSAID association studies. When I trained at IU Medical Center, the chair of medicine was Craig Brader, a pharmacologist. You could barely go a week without hearing how bad NSAIDs were for older patients, how much these drugs increased the risk of heart failure, kidney failure, GI bleeding. My friends, that was 3 decades ago. Nothing has changed on this topic in 30 years. Except my point of view. I used to be an anti-NSAID evangelist. How couldn't I be, coming from Indiana? I said, no discussion. These were bad drugs. Stop them, period. Now, I think differently. Well, first of all, association studies are always going to suffer from selection bias. Sicker patients get these drugs. A doctor had to choose to use an NSAID in an older patient. And I think it's extremely unlikely that the risk of these drugs is unknown. That means that sicker patients, those with pain and arthritis, get prescribed these drugs despite the known risk. So, of course, the renal effects of NSAIDs surely may be causal in some patients with heart failure. But also, I am certain, and you should be too, that sicker patients get prescribed these drugs. And even though the Danish authors are smart as heck, no number of statistical adjustments can negate the non-random comparisons. But there's a more important reason I've dropped my anti-NSAID evangelism. Patients have to move. Chronic pain stinks. And I know you'll say there is physical therapy and joint replacements and acetaminophen, etc. And I'm not saying that these options are useless, but some patients just feel better on a daily NSAID. So to me, their choice to take an NSAID is preference sensitive, and our job is to educate. Finally, I was one of the dumb doctors who once believed the lie that low-dose opioids were safe to use as a chronic pain drug. This might be one of the biggest errors of our generation in medicine. So NSAIDs, to conclude, I think are like coffee and blueberries. We don't need any more studies showing their hazard. Their hazard is a known trade-off. Mobility and pain relief is their benefit. Some patients can get those benefits from less hazardous means. Some cannot. For those who cannot, we are left with trade-offs. This podcast loves thinking about trade-offs and counterfactuals. The final topic today is interventional echocardiography. And I know those 2 words together are curious. The American Society of Echocardiography has issued rules and regulations for becoming an interventional echocardiographer. No, wait, I misspoke. They didn't do that. They write in their disclaimer that this report contains recommendations only and should not be used on the sole basis to make medical practice decisions or for disciplinary actions against any employee. And then they go on to write, the statements and recommendations contained in this report are primarily based on the opinions of experts rather than on scientifically verified data. They wrote that. Okay, I have a number of comments. One is that we could do with a lot less expert opinion. Here's the thing that most academic leaders may not realize. Cardiology is being practiced in the private world. If you aim to tell practicing doctors who are lifelong learners how many procedures they have to do, how many test questions they have to answer, you need to bring more than expert opinion. You need to bring us some empirical data. As I've said above, I had to learn AF ablation, conduction system pacing, CRT on my own. There were no set numbers of procedures. There were no experts telling us exactly what to do. Everyone my age went through a similar lifelong learning process with these new procedures. Well, the same thing is happening in structural heart disease. I don't think my colleagues at my institution need experts in academic centers giving guidelines on how many procedures or test modules they need to do. There is this thing called judgment and professionalism. Now, another point I noted in the document is that 2 huge sections of the document involve learning how to be interventional echocardiographers for tricuspid interventions and percutaneous left atrial appendage closure. Now imagine spending that much time learning techniques for procedures that have very little definitive evidence of benefit. Now, I've already spoken about left atrial appendage closure, but I covered the Triluminate trial in the March 10th episode. The short recap here is that Triluminate was positive, but only because of quality of life measures, and it was an unblinded trial comparing tricuspid valve clipping versus medicines. A friend of mine in academics, who will remain nameless, tells me that cardiology fellows spend oodles of time in the echo lab learning the ins and outs of measuring things like the left atrial appendage. I mean, this seems crazy to me, because fellowship seems the time to learn how to be a doctor, to learn from master clinicians. What's more, isn't it possible that AI will soon be better able to do these robotic tasks of measuring structures such as the left atrial appendage? So my note to myself is that tasks that are repetitive and requiring little human-to-human interaction or creativity will surely be replaced by machines. Finally, I really do worry about these kinds of expert statements because as much as they say they are not rules, consensus documents become standard of care. So I'll close this week's podcast by reiterating my call to experts to create fewer expert opinions. That's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. We're now over 600 ratings on Apple Podcasts, so thank you. Please, if you like this podcast, take the time to give us a rating. Write us a 1 or 2 sentence review. These things go a long way to help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.